This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, everyone. This is Andy Southerland from the University of Virginia, and I'm very pleased today to be speaking with my friend and colleague, Cheryl Bushnell, Professor of Neurology at Wake Forest University School of Medicine, and chair of the recent AHA-ASA writing group for the 2024 Guideline on the Primary Prevention of Stroke. For this week's podcast, we're going to be discussing a few of the key messages that we feel like neurologists out in practice need to know about the primary prevention of stroke. It's a large and encompassing guideline, and so I'm really excited that Dr. Bushnell is here today to help us break it down. So Cheryl, thanks for joining us. Absolutely. Thank you for having me. So folks see these guidelines that come forth from the American Heart Association, American Stroke Association. I've been part of those, as you have. And it is a process, and it's important for folks to realize what they are and what they are not. So briefly, just tell us a little bit about what went into finding the scope of this particular guideline on primary prevention of stroke, how you and your co-authors approached the literature review, chose the appropriate level of evidence and strength of your recommendations, and then sort of how that relates to prior iterations of the guideline. The bottom line is that we want to make guidelines that are clinically relevant and based on the evidence that is the most relevant to clinical practice. And we chose, as far as scope, to use both ischemic stroke and intracerebral hemorrhage prevention. We didn't want to reinvent what had already been written in other guidelines. So that was another really important thing that we listed as, what are we not talking about? And we don't need to review all the data that's already been published and analyzed and synthesized. So we also felt it was important to include really clearly what populations we're focused on when we do have cohort studies or meta-analyses of randomized controlled trials. And one of the challenges is separating out primary prevention from secondary prevention. So you have a large cohort of patients with cardiovascular disease. What does that mean? Is it coronary artery disease without a stroke? And how many people in that cohort had a stroke? And so we had to try to understand that before we decided to use that randomized controlled trial or observational cohort. That's a little bit about the process, but of course we use the standard class of recommendation and level of evidence that every AHA ASA guideline uses. So that is obviously standard. But it's been 10 years since the last guideline. So the main thing is that we've got some new evidence that we can incorporate into the current guidelines. And I'll also say just briefly that we opted to include the women-specific and gender-specific recommendations because we are not repeating or redoing the primary prevention of stroke in women. So this is encompassing really the next iteration of what we would have done for that guideline. We didn't feel like it needed to be separated. I see. And I think that is a really important component of this guideline, and I know that we're going to discuss it briefly in a moment. But as you said, it's been 10 years, and there is a lot of evidence to sort through, and you also want to make it a usable guideline. So one of the things I particularly liked about this version of the guideline is that it really leads off from the very beginning with sort of a top 10 take-home messages for folks out in practice. Not everyone is on a day-to-day basis immersed in stroke care like we are, but it's important for folks, particularly in the neurology community, but also in the primary care community, to be able to distill it down. So what are sort of beginning with sort of those top 10 messages and thinking of it from lifestyle, socioeconomic factors to more core vascular risk factors? What are several of those take-home messages you think are most relevant off the top here, Cheryl? The main thing that we are trying to communicate and our overarching goal is we need to protect the brain. And these are strategies that can help do that. Stroke can be difficult to explain in a very short sentence or catchy phrase for patients to understand. But I think they can understand that we want to protect the brain, and that is where we're coming from. And I think primary care providers can easily latch onto that as well. So we also want to close the prevention gap. These guidelines are telling us where we are in terms of the current risk factors, but we have the current level of prevention, and there's just this huge potential. 80% of strokes can be prevented, and we're probably not utilizing our full potential of risk factor management. So the top 10 messages are
a lot related to the new information that's in this particular guideline. And I would like to highlight the lifestyle factors of physical activity and sedentary behavior. I think that this is new evidence that's come out in the last 10 years. And the physical activity recommendations are fairly straightforward: 150 minutes of moderate physical activity in a week versus 75 minutes of vigorous physical activity. But I think even more important is sedentary behavior. So you could work out for 30 minutes, but if you sit for the next 10 hours and not do anything, that's really counter to the physical activity that you had earlier in the day. So getting up at least once every hour is really important, and that can in itself decrease the risk of stroke. There's evidence to show that. So that's one thing. And then the other is understanding the social determinants of health is another really important. I don't know if you can consider it a lifestyle factor, but it impacts people's lifestyles so incredibly strongly. And we just need to understand how we can improve social determinants that really limit people's access and ability to prevent stroke and other diseases. So that's it from the highlights from the lifestyle side of things.
Can you just bring out a couple of the key points and the key findings from the evidence related to women's health and stroke? And you also mentioned gender-specific concerns and issues related to stroke risk.
Pregnancy is one of the things that we highlighted in our Prevention of Stroke in Women guideline in 2014. And since then, there's been an enormous amount of data showing that women who are pregnant and have high blood pressure are at extremely high risk of dying from intracerebral hemorrhage because of that untreated hypertension. And so that is one of the things that we really are underscoring. And then the other newer evidence and thinking is around this whole category of adverse pregnancy outcomes. So there's about 10 different complications that can occur in pregnancy, and individually they've all been shown to impact cardiovascular disease later in life in some capacity. And so obviously one of the most important ones is the hypertensive disorders in pregnancy, such as preeclampsia. And that category alone had been in isolation. But when you add together premature labor or postpartum hemorrhage or a variety of other things that happen during pregnancy or postpartum, then this could impact 1 in 10 women who give birth. So this is a large population of our female members of society. I think it's really important to emphasize that. And what we did in the guideline, and I'll credit Eliza Miller with this, she was just amazing and came up with an algorithm to sort of screen for each of those adverse pregnancy outcomes. And if you do screen positive for them, you can really emphasize cardiovascular risk factor management, or obviously the lifestyle aspect of things if they don't have hypertension or hyperlipidemia or diabetes. So there are definitely things that can be done. I'll just mention quickly that women who have premature menopause or early menopause, basically before the age of 40 or before the age of 45, that is also an established risk factor for stroke. And unfortunately, we don't have necessarily anything that we can do about it other than recognize it and screen those women for cardiovascular risk or stroke risk. And then obviously hormone therapy, there's nothing really new there in terms of establishing the harm in certain women. And we did create a figure showing that there are circumstances where it's safe and others where it's not. So we did try to outline what those are, and if people are interested, they can look to the guideline for those details. And then one last thing is endometriosis, which is an inflammatory disorder. Extrauterine tissue is causing inflammation, pain, and this has been shown to be a risk factor for stroke as well, presumably because of the inflammatory processes that are happening. And then hysterectomy is often the treatment for it, which could also cause complications as well. So I think it's just really highlighting that there are unique things that women experience that should be recognized in primary care and in neurology practice as well. I think we see a lot of young women, headache clinics or general neurology. There's a lot of opportunity for neurologists to screen for these women who may be at risk as well.
These things certainly come up in our migraine population, and we all get referrals, particularly for women who are screened to be high risk from OBGYN, and we need to be able to to speak this language of primary prevention and understand what those risk factors are. When you look at this guideline, we think the 10 years ahead before the next perhaps update of the guideline. What are some of the lingering questions?
There are several areas, and every single topic has knowledge gaps listed underneath it, and you can see what those are. But I think the largest ones are related to sleep. At the time that we did the literature review, we couldn't say a whole lot of definitive things about obstructive sleep apnea, sleep duration. I think that there will be more data forthcoming, but I know that there's a lot of questions still remaining about what to do about sleep in terms of primary prevention. I think the other big category is what are the interventions that we can do to address the social determinants of health. If we identify them, but then when we know that they are going to impact an individual's ability to access primary prevention services, what do we do about it? So that is another big category, and maybe beyond the office setting, is more public policy in some ways and in the hands of insurance companies. But that is something that I think is going to be really important for the health of the country. And then the third thing is what to do. You mentioned asymptomatic carotid stenosis, but what to do when you find an incidental stroke on MRI. This happens all the time. And we're like, well, okay, this stroke happened sometime in the past. There's been a change in the last year since they had their MRI. There's a stroke that shows up. What do you do? There's no evidence to say that starting aspirin is the right thing to do. But I think our instinct is, well, we've got to do something because look what happened. This is probably important, and it could be related to uncontrolled diabetes, hypertension, hyperlipidemia, smoking. Could be all those things, but we still think we should add aspirin. But the evidence contradicts that.
That certainly is our instinct, and probably one that we are labeled with appropriately. Our other neurology colleagues in vascular neurology is we do love aspirin. We love our antiplatelet therapy, but you're absolutely right. Perhaps we should explore, investigate, do they need a cardiac telemetry or other risk factor evaluation? But as far as interventions go, maybe our instinct should be hurry up and do nothing. That is an important aspect of the guideline as well. And I'll also just reiterate something you said, Cheryl, the importance of these guidelines when it comes to policymakers and administrators. I think there's real value in that, and hopefully it will make its way outside of just the medical community to be part of those conversations at a higher level as well in these next few years. So Cheryl, we could continue on, and we will provide some additional snippets in our Neurology Minute segment, so I'll foreshadow that for our listeners to check out. But do you have any final thoughts or words before we wrap up here?
My main final thought is that we are recommending these interventions and guidelines for the protection of the brain. And it's not only to prevent stroke, but to prevent dementia as well. And I think it's just really important to think about it that way. There are people who are having strokes at younger ages now. And a lot of people may not be thinking in their 50s about dementia, but the things that this guideline recommends could prevent them from having a stroke, but also from having dementia and really losing their cognitive ability and who they are as a person. And so I think that that's obviously something that hits home to everyone, myself included. I have Alzheimer's disease through my entire family. So it's really important to find ways to really protect the brain. And in the meantime, decrease the risk of stroke as well.
Well, such an important send-home message is that the increasing overlap or collision between what we understand about stroke and stroke risk and neurodegenerative disorders at large, but particularly Alzheimer's disease. And that sort of focus on overall brain health throughout the lifespan is something I know that's important not only to the American Heart Association, but to the American Academy of Neurology as well. So it's so apt that we're covering this in the podcast now. So I'll just say this has been a wonderful interview. I really congratulate you and your team for this work. I know how much time and effort and years go into making these guidelines. And so, Cheryl, thank you again. This has been Andy Southerland with Cheryl Bushnell discussing the 2024 guideline from the American Heart Association on the primary prevention of stroke. I encourage all of our listeners to seek out the full guideline as both a reference text, but also an important piece of information for providers and patients alike. So, Cheryl, thanks so much for joining us again.
Absolutely. My pleasure.
If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.